Welcome to the Brain Coffee Podcast, where doctors Eric Luthard and Albert Kim unlock life's little mysteries about health, wellness, entertainment, technology, and how the brain makes sense of it all. Sit back, relax, and open up your mind.
Well, first off, Josh, thank you very much for joining us for some coffee at Brain Coffee today.
Maybe it's fitting. We were just finishing our bacon kolache, so maybe the topic that Josh is going to talk about is very appropriate. Yeah.
So maybe just a brief introduction. So Josh obviously is a rising star in the field of neurosurgery and stroke. So I think having the opportunity to talk about stroke and kind of what's going on with it, it's great to have you here.
Yeah, everyone's interested in it.
Yeah. So maybe before we even really get started, why don't you tell us, because obviously I think we all know, but
we talk about it.
But how do we define what exactly a stroke is?
Yeah, so a stroke is really just any sudden onset acute insult to the brain, in its simplest definition. And can come from a couple different sources. The most common thing we think of is that a vessel somewhere in the brain just suddenly gets blocked by either a blood clot or a piece of material that breaks off a blood vessel wall coming from another place, and that part of the brain is being starved for blood supply, and so whatever it does just stops working, and the patient will have an issue because part of the brain is not working suddenly. And then it can also happen because a blood vessel just bursts in the brain, and you have bleeding in the brain, and it just happens suddenly in the same way. So people came up with the idea of stroke because they originally thought that it was the gods punishing them for something, and it was Zeus throwing a bolt of lightning from the sky and striking them down suddenly for breaking his rules and his laws, and so it was sort of a stroke of lightning from the gods originally is where it came from. So
could still be true.
Yeah, right. But I think that element it's sudden, right?
And there are two different kinds.
Yeah,
right?
There's sudden. And there's two different kinds. That's right. Either, really, in some senses, either too little blood, meaning not enough, oxygen, or too much, meaning the blood kind of essentially is like a little bomb going off in part of the brain.
Okay, so maybe we could talk about them separately.
Yeah.
Why don't we talk about the block first? So not enough blood, and we all know time is brain, right?
Yeah.
So once it's blocked.
Maybe explain that, unpack that. Why is time brain?
That's so. What I've heard, and correct me if I'm wrong, is that if your blood vessels in your brain are blocked up, you have something on the order of 5 minutes for that blood to come back to that brain so that brain can live. So a part of the brain starved of blood for 5 minutes will die, or something.
We used to think that, but that's not necessarily true.
Rising star, tell us. Yeah, exactly.
So we found that everybody has a completely different profile of their brain, how they get blood supply, how long they can go without oxygen, and so people are kind of divided into fast progressors and slow progressors, and unfortunately I have no way of telling you, a random person walking down the street who, if their brain is starved of oxygen, is going to be a fast progressor and they're going to die in 5 minutes, as you just suggested, or they can go for 24 or 36 hours before it dies. And that's, I think, one of the big hot things in stroke right now is we're trying to figure out who are the fast progressors, who are the slow progressors, because we found that we can actually help these slow progressors for a very long time, and we haven't lost a window in treating them.
So it's almost like, for instance, people can hold their breath for different lengths of time.
Exactly.
You know what I mean? And so kind of your brain is the same in the sense that I guess some people, because whether it's because of their genetics, their metabolism, their blood flow, their brain can hold its breath because it's blocked for a period of time, whereas some people are really wimpy.
But the stopwatch is still going. It's just like the length of time.
Is always going.
Yeah, but the length of time is different.
You assume time is brain. You assume everybody is going to progress, but we found that it's not the same time for everybody, and that everybody's worth a look a little bit deeper.
Well, what's cool about that is that really does give more hope to the situation, right? Because I think I think that the time is brain, right? 5 minutes, you're gone, it's done,
right.
And but now we're expanding that window of hope, a multitude of levels.
Yeah. So what can we do about it? So let's.
Well, there's a lot of things you can do about it. It all depends on how severe the symptoms are and what the time window is. So one of the biggest revolutions in stroke came in the late 90s, which was a clot buster called TPA. And we found that if we give TPA within 3 hours of the onset of symptoms, the majority of patients, about 30 out of 100, would get better from their stroke. after a few days.
So that busts the clot inside the
Yeah.
vessel, so then the blood flow resumes. Is that the idea?
Exactly.
Okay. Gotcha.
So TPA was really the first just big game-changing stroke treatment. We've been using it for almost 30 years now, I guess 2025. And it's really been our mainstay of stroke. And what's been exciting about TPA is that as the last 20 years have progressed, we found that the window wasn't just 3 hours. We found that certain patients we can extend it out to 4.5 hours, and now we're even looking at extending it out to 9 hours, and even looking at extending it out to 24 hours in certain patients, based on getting the right images to prove that their brain's actually still hanging on, and they're worth still trying to bust up the clot with medicine.
Oh,
Yeah,
wow.
but TPA is not for everyone, isn't that
No,
right? Like,
TPA is not for everyone. It is a very powerful blood clot or clot buster. Can definitely induce bleeding anywhere in the body. It's probably the most powerful blood thinner in medicine that we have. Certainly if you've had recent surgery, if you're already taking another blood thinner, or you have certain bad medical problems, TPA is actually dangerous for you, and the chance of it causing a hemorrhage somewhere in your body, whether it's your gut or your brain, is just too great, and it's really not worth what it might do for your stroke, because it's going to cause another devastating event.
Right.
So,
I see. But if you're one of these people that's eligible for it,
Yeah.
then it's not 5 minutes anymore. You got
Exactly.
maybe, fast as possible is still better, but you still have several hours.
So 3
maybe.
hours for anybody out of the
Yeah.
box, as long as you haven't had recent surgery or one of these, other things that keep you from getting TPA. And then certain patients go out to 4.5 hours, and now out to 9, and we're even starting to do research on out to 24 hours.
And I think, kind of one of the take-homes for me when I think about this, actually there's two of them. One is, if you have a sudden event where something's changed with you, that means you need to see a doctor or go to an emergency room right now.
And that's,
right? Because
that's a really important point, because if you look at statistics that the CDC gathers on stroke and whatnot, they actually found that, in a big survey a few years ago, that out of all the people who had a stroke, only 38% of people actually knew something was bad enough wrong with them that they should actually seek medical attention. So there's a huge opportunity for people to understand that you have a sudden event, an arm's not working, I can't talk, my speech is slurred, I've suddenly gone blind in one eye.
Don't
sleep
like,
it off.
you know,
You need to go immediately to the hospital and get evaluated. That's probably
that's
a
really
stroke, and there's
Yeah.
probably something we can do about it.
Right, and I think the second point that I was thinking about is that, and I think this is going to get to talk about some of the other stuff, is that TPA is for some people, not for others.
Yeah.
But there's a number of different things that are emerging that can really have an impact. I mean, obviously you do a lot of that.
Yeah. So, aside from medicine, the most exciting thing I think that's happened in, cerebrovascular disease and the last really 100 years is thrombectomy for stroke.
Okay,
what's that
what
mean?
does that mean? Exactly.
So that means rather than assuming a medicine's going to bust up this clot and get the vessel flowing with blood again, we're not going to rely on the medicine. We're actually going to go up through the arteries of the body. We usually use the leg artery, which is a big artery you feel at your groin crease, and we can actually take tools inside the artery all the way through the body up into the brain, and we actually have devices that grab onto that clot and remove it from the blood vessel instead of relying on a medicine to break it up. So
it's really a roto-rooter.
Yeah,
right?
roto-rooter
Yeah,
brain.
exactly.
Okay, and it's minimally invasive. The way you're
minimally
describing
invasive,
it?
yeah.
Okay,
So
gotcha.
just through a small needle poke into a blood vessel. So
It's amazing.
And so I guess, and that's more recent, right? People have been working on it for years, but I think it's really come to its own. And really, I guess, how many years?
So, well, I mean, honestly, if you look at the medical literature, the first time people had this concept was as early as 1958.
Oh, well, maybe not so recent. Yeah, right, exactly.
But for it to be actually practical and have
be
stuff that work,
successful,
I would say the first devices really came to market around 2006, 2007. We didn't have great success, mainly because patient selection was not right and the devices weren't as good. And then there's a lot of hope, from 2010, 2012, 2013, that the next generation of devices is really going to be the game changer, and we still found that those weren't working as well as we thought. But all of us who were doing stroke treatments knew that we always had these patients who were having a severe stroke. We got a clot out, and they were instantly better as soon as the clot was out.
I see.
And so we knew that this was going to work. We just had to get the devices right and the patients right, and everything was sort of came back to the table, and in 2015, there were 5 just large landmark studies that show that this treatment was just revolutionary, and that without a doubt it worked, and that it made patients with severe strokes better. For the most part, pretty instantaneous.
What I think is really cool about this is the
4 years ago, wow.
Yeah, the persistence. For instance, it's all about fighting the good fight.
Yeah,
in the sense that really that
doggedness.
Doggedness. You failed once. It didn't go so well. You didn't get it quite right. Again, even the second round of technologies didn't quite make it. It didn't achieve. But there's this persistence, and vision to say, hey, look, we can get this to work. And
60 years later, honestly, what you said. Yes.
I think that speaks well of kind of our system and our scientific endeavor for kind of really getting past a hard problem. Because stroke is obviously a hard problem.
Obviously, yeah. So tell me more about it. When you have to do this thrombectomy, is it like?
So again, time is brain. Time is brain. So you want to do it as soon as possible. I think it's important to know that there's a huge variety of strokes. Some people have very minor strokes. Some people have really severe strokes. So this is really for the more moderate to severe strokes.
Bigger ones, okay.
And we're looking for some of the larger blood vessels in the brain, so we call it a large vessel occlusion. But these are the strokes that if they're left untreated, are going to be much more devastating to the patient, and are also the ones that the medicine, the TPA, is not nearly as effective for.
I see.
So really, it's really complementary.
So it's probably out of all the strokes, it's probably somewhere between 20 and 30% of all comers with strokes are eligible for this treatment.
That's a lot.
But these are also the ones that are going to have the really bad strokes. So these are the ones I think we have the most to benefit from. So
people like paralyzed on one side of the body or something like that. Really
so we found that if we put everybody sort of in the same pool, that anybody who's within 6 hours of their symptoms is worth treating, and they're probably going to get better. Probably at least 2 out of every 3 patients are going to get significantly better with the treatment. If we treat them within 6 hours. So, and that doesn't matter who you are, if you're a fast progressor or a slow progressor, we don't even discriminate. We just assume that everybody under 6 hours has a really good chance of getting better.
I see.
After 6 hours, we've got to do some special imaging called perfusion imaging, and we look at how much of the stroke has already taken hold of the brain. We found a lot of patients, they don't have good perfusion, but the brain isn't dead yet.
I see.
And
right. So
there's
maybe
stuff
just
to see.
right. So basically, perfusion means like there's still the brain's not working, but the blood's still flowing. There, right?
It's still getting there, and through alternative pathways, but those little alternative pathways are just not strong enough to make the brain hold on forever.
Right.
So
just like hanging on a cliff.
Exactly. Literally, fingers on the edge of the cliff. That's right. Yeah.
Okay.
So our goal is to get to the patient before they fall off the cliff.
Right.
And so we found that with this special imaging that we can intervene up to 24 hours now.
Oh wow, that's a long time.
So
right, pulling you over the edge. That's cool.
Yeah.
Well, that's great. So that's the artery blocked side of things, right? So I know you mentioned the other side. If the artery busts open like a bomb. So what kind of things cause that?
Well, there's a lot of things. So some people have just high blood pressure, that the pressure in the blood vessels overwhelms the vessels, and literally a vessel just explodes and ruptures, and that will cause bleeding in the brain, and sort of literally a blood clot will form in the brain. Some people have blood vessel problems like an aneurysm. That's when you have sort of a weakening of the blood vessel wall, and it sort of forms a blister. And if you can imagine just having a blister on your skin, eventually that blister can pop.
Right.
And that can cause bleeding on the undersurface of the brain. We call that subarachnoid hemorrhage is the technical term for it. And that's when an aneurysm bleeds. That's a form of a stroke.
Just as a very crude analogy here.
Yeah.
I remember my basement flooded. Right, and it actually flooded twice for 2 very different reasons. One, basically, kind of it was a really bad rain once, and basically the sewage system backed up. Right, that's the equivalent of hypertension. Right, like the pressure was too high, and then blood, went into my basement. And another time, basically a pipe burst. Right, and basically the pipe.
It's a weak pipe,
it was
like
a weak
an aneurysm.
pipe. Right, exactly, like an aneurysm.
Yeah, that's a great analogy. Yeah.
Yeah.
So then we have high blood pressure, we have aneurysms, which are this balloon thing you're talking about. Anything else that can cause that?
Sure. I mean, there can be all sorts of blood vessel problems, something called an arteriovenous malformation, which is sort of a almost like having a birthmark on your brain that you're born with, and those are prone to bleed. You can have various forms of just these deposits in your brain that we call amyloid angiopathy. And that's sort of related to Alzheimer's disease.
I was just about to say,
Yeah. So I see. So the people with Alzheimer's can also have these.
They get these sort of these plaques that develop in their brain, and that weakens the blood vessels and can cause you to sort of spontaneously have a brain hemorrhage. So
wow, I see. So can we do anything about these?
Sure. So there's a whole slew of treatments for aneurysms, and we can do anything from operate on them, and we place little metal clips across the base of the aneurysm and pinch them shut. We've been doing that since the 1950s and still do it a lot today. And then more excitingly are the inside the blood vessel treatments, the minimally invasive treatments with all sorts of little metal coils that block off the aneurysm. Sometimes we put stents in that divert blood flow.
Let's talk a little bit more about that, because I think it's almost hard to imagine.
No, you're right.
Okay, so we've got this blister, right, on a blood vessel.
Let's say these are vessels, and you got this blister in the middle, like the balloon in the middle.
Right?
Yeah.
And so one is you can. Great. And so basically one is you can put a clip across it, right?
On the outside of it.
Literally going on the outside and pinching it off, right? Pinching the blister off. But then talk a little bit more. Now you can go inside the vessel. How do you fix the inside of a vessel wall?
Sure. So just like the strokes, where we snake our way up through all the blood vessels of the body, we do that for aneurysms. And instead of taking out a blood clot, here the idea is to actually induce a blood clot in the aneurysm only. And so we kind of park a tiny little catheter, which is just this thin tube. It's about the size of a piece of angel hair pasta. And we can actually guide that all the way through the body up into the brain and put it just right at the entry part of this little blister.
It's a long piece of pasta.
And then I mean these are this long. So and then through that we just deploy these little metal coils, which are these strands of platinum, and we pack enough of them in the aneurysm that it blocks it off.
So basically, right,
I got it.
Good.
So like basically the inside of the aneurysm is clotted off.
That's
like
right. So whereas it clots, I mean, it's actually kind of a very interesting thing. There's times that you do not want to clot in the blood vessel, right? Because that's going to cause the stroke that causes loss of blood flow.
Right.
But there's times when the pipes burst, because you've got a blister, you actually want a very specific, essentially well-controlled clot to form on the inside of this vessel so that it basically doesn't burst anymore.
Yeah.
That's really neat.
Yeah, I see. So when do you do the outside method versus the inside out method?
Well, the aneurysms come in all sorts of shapes and sizes, and no two are alike. And there are times when we obviously like to use the minimally invasive method because the patient doesn't get a big surgery, but sometimes that's not the safest thing to do because we can't be precise enough with it. And when we're doing the open brain surgery and the clipping, we really have the maximum amount of versatility, and we can precisely place these clips so that it just really takes care of the aneurysm and doesn't occlude a normal blood vessel, because you don't want to pinch off a normal blood vessel with the clip, and you don't want to block off a normal blood vessel with the coils, because that will obviously cause a stroke. So the clips provide the maximal versatility, but they also provide the maximum amount of invasiveness and the biggest procedure for the patient.
So there's make a decision, their scalp, a hole in the skull, and really go into the folds of the brain.
So it comes at a price. Whereas the minimally invasive treatment from the inside of the blood vessel, with the technology today, we can probably treat 90% of aneurysms that way.
I see, not all of them though.
But not all of them, and so we try to do it when we can. Certainly if an aneurysm is bled and it's ruptured and the brain's in sort of a swollen state because of the bleeding, we found that patients don't like to have their heads opened up in that state. And
And angry. Really don't touch the angry brain.
Yeah, well, it's kind of like if you had a bruise on your arm, or if you really injured yourself. Anytime you have to touch it or manipulate it more, it hurts and it's more susceptible to injury.
That's true. But it's interesting. So it depends on the person and the aneurysm. Then if you use the coils from inside the vessel or the clips from outside the vessel, I see. So it's interesting because in a lot of other things that we do, right, maximally safe is not necessarily minimally invasive.
Right.
Sometimes maximally
Right.
safe is maximally invasive,
Exactly.
right? It's
Right.
just what you need.
It's this careful balance, and this is where I think, again, computers won't replace us just yet, because we really need to create this fine judgment of, what is the optimal strategy for a given individual for a given problem that they have.
Interesting.
But every couple of years, the devices progress further, and there's more aneurysm shapes that we can fix from the inside, and the technology is exciting. It's always evolving.
Any robots or things like that being used for any of these things?
Well,
we
things
use
are
robots.
things are actually in development for robotic inside the blood vessel techniques.
Wow.
And it's actually made a lot of progress in interventional cardiology for heart procedures. And in India, there's actually a robotic company that's found that a doctor 30 miles away from the patient can control the devices that go in the patient with a robot and do heart stents and open up people who are having acute heart attacks.
Well, it seems like that type of technology really expands the scale of which you can kind of essentially touch people, right?
Yeah.
Meaning that, like, again, there's people in communities. We were talking about time is brain. That if you're 100 miles out, 200 miles out in a small
Rural Missouri
town,
or something
right?
like that,
And
where you don't have Dr. Osmond there.
right, exactly. And
that's
like,
the
how do you
problem
get to
with
them? And
stroke
how do they
is-
get to you?
Is with time is brain, and it's, if you look at all the metrics in the United States in terms of how many people are within an hour of getting to a hospital that can treat a stroke, it's really almost 75-80% of the population, but the distribution is terrible because a lot of our population in the U.S. is along the coast, on the west coast and the east coast and the south coast, and so that all has just this plethora of centers that can take care of this. But if you look at the middle of the country, where there's a lot more vast areas of land and travel to a big center that can do this, we've got a really bad distribution of hospitals, and a lot of patients just don't have access to that kind of care. So anything that can extend the doctors that have expertise in this, like
Extend their reach.
like a robot that's well positioned somewhere that somebody else can control. I think the future is really bright for having more patients in our country have access to this kind of treatment.
Although I think a take-home point for the here and now is that not all hospitals are created equal, right? So you really got to go to the right place.
Even forgetting about robots.
Exactly.
The things you can do everywhere, right?
Right. And so you have to be a little bit judicious to think that not all hospitals are the same in treating stroke, and so you got to go to the right place right away. So I guess, and all the really amazing emerging technologies when people come in with a stroke. So I guess, how are they doing?
So a lot of patients, within minutes or a few hours after us finishing our procedures, will get instantly better and reverse all their symptoms, and it's really amazing and miraculous. Unfortunately, that's not everybody. We found that on the whole, within about 3 months, 90 days or so after one of these procedures, that the majority of patients will get back to living independently and being able to take care of all their own needs and be fairly mobile and walking around and able to run all their own errands and hopefully return to work. But then there's still definitely some patients, probably about a third of them that they end up having some sort of disability after a major stroke like this, and they can get a lot better over many months by doing intensive rehabilitation. But it takes a lot of work, and some of them are left with really permanent deficits that really affect their lives every day. So
you think about, what do you think, like in about a year it's settled out, and it's sort of what they can get out of
a year, 18 months we
rehab
think they have their maximum benefit from rehab, and they're really as good as they're going to get. So
but people like yourself that are working on things beyond that year, right?
There's still reason for hope, and I think that's the cool thing, is that there's still a continuum of hope here, because certainly in my laboratory we're working with technologies to see if we can rewire and recover the brain long after the injury has settled down. And it's this idea of what we call a brain-computer interface. This idea where you basically take signals from the brain, essentially capture the patient's thoughts, and allow them to control something and see if in the process of doing that you can rewire the brain.
So they use the force or something.
Well, not quite
Something
the
like
force, no. Yeah. Well, so just as I think we've seen really kind of an amazing progression of technology and technical capability in the treatment of acute stroke, but these through the vessel technologies, we're also seeing a real renaissance of how we can use computers to decode signals from the brain.
I see.
And this idea of, as an example, if you have a stroke patient, even in the chronic stage, and they can't move their hand, for instance.
Right, so now we're a year out from, Dr.
right.
Osmond doing everything he can.
That's right.
Things are settled out, they still have a disability.
That's right. And so, now one of the most common persistent deficits after a stroke is that they have a paralyzed hand.
Right, oh yeah.
And now, they may not be able to move their hand, but they can still imagine moving their hand.
Right.
They can still think about moving their hand. They can still try to move it, they just can't actually do it. And so where are those thoughts coming from? And so we're starting to really explore and understand the ideas of where those thoughts are coming from. So part of it is they're coming from kind of one side of the brain that controls that paralyzed limb, which is damaged, but there's actually signals and physiology associated with thoughts to control that paralyzed hand on the uninjured side of the brain.
Oh, that's different from what we learned in med school.
Exactly.
Yeah.
That's right.
Yeah.
And and we can tap into that. And again, we don't have to put, it doesn't require surgery, but you can put electrodes on the scalp, record brain signals, and again, with computers and essentially new computer algorithms, you can pick up those signals and decode that a person wants to control their paralyzed hand with their uninjured side of their brain.
I see.
And the reason that that's important now,
That's cool.
it is cool, because now what we can do is we can allow them to control things. And we're starting to use systems where basically people are wearing a headset, they're wearing an external robotic, and they're controlling their paralyzed hand with this wearable robotic. Mm-hmm. And in the process, when they continue to do that over time, it's almost like a new form of rehabilitation for chronic stroke. They're gaining function back, and that's one of the things we published a couple years ago.
Oh wow! I mean, do they have to keep wearing the thing, or?
Well, they wear it for
robotic?
they wear it for a few months, and then after a few months, after continued usage, then they start to they actually gain that function back themselves. Essentially, the uninjured side of the brain is taking over control of the paralyzed hand.
I see. Without the robotic.
Without the robot. That's right.
Cool. So, I mean, that probably would apply to any one of your patients, for instance, in the long term who have chronic problems, whether it's the loss of blood flow to brain and you have some injury, which is what you're talking about.
Yeah, right.
When you talk about this, I always think of one of my favorite movies when I was growing up, which is the Star Wars series, and how Luke gets his prosthetic hand after he loses it back.
We're just a little shy of that, right? That's the first step.
But we may see it in our lifetime. We never know. So.
Yeah. No, I think that's right. And I think this really is kind of, these are the first emerging technologies of how we can tap into the power of the brain to essentially kind of change our brains and our bodies for the better. And I think we're going to see a lot more of this stuff come down the pike.
Cool.
Eric, like you're talking about all your brain-computer interface research. I know you're very excited about it, and it's been not just a scientific outlet for you, but also a creative outlet for you. And aren't you sort of designing a play around all of this right now?
Well, not just me. It's Albert and myself. Like, in addition to kind of our filmed coffee conversations, we wrote our first play back in 2016. Is that right?
2014.
That's okay. So so you're right. So you're absolutely right. So in addition to brain-computer interfaces have been a long inspiration, whether it be I've actually written a couple novels, but Albert and I have been working on plays actually for many years now. Our first play was in 2014, that was Brainworks, and now we have another installment of Brainworks coming out. And
it's coming out this summer, July 2019.
That's right. And again, it's a 3-year work in progress.
Right. And we do talk about brain-computer interfaces.
That's right.
And stroke, like you've been talking about. No.
And it really is a multitude of clinical stories where I think because I think one of the things that's so important is that when we do talk about technology, in addition to kind of the conversations that we're having now, I think people need to engage with them. And we do have a story that has really been inspired by one of our patients about how he recovered using a brain-computer interface after stroke.
That's amazing.
Yeah. Should be fun.
It'll be fun, yeah.
It's deeply uncomfortable getting ready for it, of course.
That's right. We talked about the cognitive marathon, like where it is quite literally easier to do neurosurgery than to prepare for a play.
Yeah,
like
memorizing lines, all this stuff.
And knowing your position, but it's a whole lot of fun.
Yeah.
So funny, I always laugh when people say that things are not brain surgery, because I think there's a lot of things in life that are way harder than brain surgery.
Absolutely, absolutely.
It's a hidden secret.
I know. We'll delete that out.